Well, thank you for having me, at least virtually, and we'll go ahead and get started because we have a lot of material to cover. So, as you can see here, the outline of topics is pretty diverse, represents some of the core issues facing internal medicine in neurology, includes neuromuscular junction disease, peripheral nerve and back pain, muscle disease, motor neuron disease, vertigo or dizziness, movement disorders, headache, epilepsy, stroke, dementia, and multiple sclerosis. So we'll get started right away with the case and an audience response question. A 33-year-old female presents with ptosis or lid lag of the left eye. On exam, she has dysconjugate gaze that worsens with fatigue and has weakness of her proximal arms and legs. Her sensation is in fact normal and her reflexes are normal at 2+. She has no dysmetria or discoordination on finger to nose testing and no ataxia. This is a video of this particular woman, and you can see the severe lid lag on the left. And what they're about to do is apply an ice pack to that same eye. This is a two-part video, so this is part one, and I'll show you part two in just a moment. But basically, part one consists of applying the ice pack. I will advance the slide, and what you'll see here is they're going to remove the ice pack and see what happens. And I hope you can appreciate that the ptosis or lid lag has improved significantly on the left. It's not back to normal, but it has improved. So the first audience response question is which test is most likely to be abnormal in this patient? Is it A, MRI of the brain, B, CT of the chest, C, CT of the abdomen, or D, MRI of the cervical spine? And you guys are probably pros at this system already. So we'll let this go forward and have a lot of already good responses there. Okay, great. And the majority of you answered B, CT of the chest, which is the correct answer. And that's because this patient is more than likely facing myasthenia gravis, one of the major neuromuscular junction diseases that would be tested. The clinical features of myasthenia are actually most commonly ocular or bulbar referring to the brainstem and meaning symptoms around the face or throat, like dysphagia and dysarthria. It does also involve the appendicular limbs, but it typically is more proximal than distal and has an element of fatigability or worsening of the weakness with use or over the course of a day. The evaluation of these patients includes acetylcholinesterase receptor antibodies. There are 3 subtypes, although they generally come as a single block clinically with binding, blocking, and modulating. However, if that's negative, we often advocate for further testing with MuSK antibody. That stands for muscle-specific kinase. And when you combine these 2 antibodies, they really form the majority of patients with antibody-positive myasthenia gravis. Combine that with an electromyographic study, which shows a characteristic decrement in response to rapid stimulation. And the answer to the question was CT of the chest because you're often there to rule out at least thymoma, although patients also commonly have thymic hyperplasia, and it could certainly also be normal. The treatment for these patients includes anticholinesterase therapy, the primary being pridostigmine. I will say clinically, if you're doing this in the clinic, make sure that you are there for potential testing because they can get a bradyarrhythmia from it. Oftentimes patients do require chronic steroids. In an effort to sort of spare them from chronic steroid use, we often offer plasmapheresis or IVIG, certainly in acute crises, but occasionally we'll have patients on intermittent plasmapheresis or IVIG as a suppressive or maintenance therapy. And then surgery with thymectomy is not controversial when it's applied to thymomas. In fact, it's the only real way for potential cure in young patients and good candidates for this. There is a little bit more controversy as to whether or not the thymus should be removed in the setting of general thymic hyperplasia, and even more controversial in the setting of normal appearing thymus glands. Other immune suppressants that are used, again, to spare them from the use of steroids includes azathioprine and mycophenolate. Here's a picture of that electrodecrement that I was referring to. As you give rapid stimulation on EMG, it actually decreases throughout in its amplitude, which is characteristic of myasthenic syndromes. Now, on the differential diagnosis of myasthenic syndromes is Lambert-Eaton myasthenic syndrome. Symptoms may be very similar to myasthenia. However, they characteristically describe what they call facilitation. So instead of the classic fatiguing you hear about in myasthenia, these patients will actually be worse in the morning, for example, as they first get up from rest. And if they move their muscle groups, they'll actually get sort of an increase in power. Now, on a more sort of clinical note, I will say that people still often get a decrease in strength or fatigability over the course or time scale of a day. They'll still feel a little tired at the end of a day, but there is this characteristic facilitation that does not typically occur in myasthenia gravis. Half of the cases are associated with neoplasms and are considered paraneoplastic, the most common association with small cell lung cancer. And reflexes are typically down or hyporeflexic in this condition and normal in myasthenia gravis. There are also more autonomic symptoms like dry mouth, blurred vision, constipation, and impotence. Involvement of these voltage-gated calcium channels in the presynaptic area make this different from myasthenia as well and result in that increment also on EMG. So that decrement I just showed you for myasthenia would be quite the opposite for rapid stimulation in Lambert-Eaton. This particular discussion pertains to the differential diagnosis of patients with myasthenia-like symptoms, but this 25-year-old male patient presents with acute dysphagia or difficulty swallowing for the past 2 days. He's found to have ophthalmoparesis or difficulty moving his eyes, bilateral ptosis or lid lag, proximal muscle weakness, and decreased reflexes. His sensation and coordination are also normal, but his pupils are enlarged and poorly reactive. This is an example of his pre and post 10-second exercise of thumb, demonstrating a similar increment that I also mentioned occurs in Lambert-Eaton. But this is not Lambert-Eaton. This is a different condition, and it is botulism. The differences in this case that were keyed into that key feature would be the pupillary differences as well as the entirely dropped reflexes. So after EMG, he did admit to injecting drugs with a used needle 2 days prior to the onset of symptoms. Foodborne wound and illicit drugs are the most common causes of botulism in adults, and the treatment, of course, is with botulism antitoxin therapy, and of course, contacting the CDC. Okay. Audience response question number 2. A 44-year-old female presents with a 2-month history of waking up at night with her whole right hand tingling. She has pain in the wrist at times, but no pain elsewhere. Past medical history is significant only for hypertension and hypothyroidism. Medications including hydrochlorothiazide and levothyroxine. On neuroexam, she is alert and oriented ×3. Cranial nerves are just fine, but there's decreased sensation over digits 1, 2, and 3 on the right side, 1, 2, and 3. Muscle bulk and strength are normal, however, and she has normal reflexes without dysmetria or ataxia. So the question is what is your next best step in management? Is it A, night splints, B, MRI of the cervical spine, C, steroid taper, D, steroid injection, or E, orthopedic hand surgeon referral? Great, wow, okay, so very clear answer there is conservative treatment with night splints, because of course what we're referring to in that scenario is a median neuropathy, or more commonly called carpal tunnel syndrome, when that neuropathy is at the wrist. Typically having sensory involvement of the first 3 digits, sometimes classically splitting the 4th digit, usually having nocturnal symptoms that are worse. Tennell's and Phelan sign are exam features that are sometimes positive and often quoted, although the sensitivity in real clinical work is probably not that high. More severe cases will have weakness as well as atrophy of the thenar eminence or the thumb pad. EMG nerve conduction study can be useful to localize and grade cases. However, for milder cases, all you really need to do is brace people at night, maybe even do some modifications behaviorally at work if they're like me and at the computer a lot of the time. Steroid injections can be used as an intermediate option, and then more significant or severe cases need to be sent for surgery and potentially carpal tunnel release intervention. Now, on the differential, when you have a patient with numbness of the hand or certainly the upper extremity, there are some nerves to know, including the ulnar neuropathy that is classically compressed across the elbow or the olecranon fossa, the groove in the elbow, the classic funny bone scenario. If you ever knock it, you can actually sort of feel where the numbness is, classically in the last 2 digits, sometimes splitting the 4th digit. It gives you that medial hand sensory loss. More severe cases will actually give you interossei weakness. That's most demonstrated on exam with finger spreading weakness, as well as atrophy of those same interossei. EMGs, again, can be helpful in localizing in more complicated cases, but for milder cases, you really just want to avoid resting the elbow precariously on things, and more significant cases may require surgery for entrapment release. And then lastly is radial neuropathy of the 3 nerves to know related to the forearm and the hand. Classic Saturday night palsy, so called because it describes people who used to fall asleep, usually inebriated, onto their spiral groove in their arm, and then they would classically get a wrist drop thinking they perhaps had a stroke and appearing in ERs around the country. You can use the EMG to localize those patients, but typically it's supportive care and they typically have excellent recovery, which is good news until the next Saturday night. Okay, now that's nerves of the upper extremity. What about the lower extremity? Well, these are individual mononeuropathies or single nerve neuropathies, and pathologies include femoral neuropathy is one of the more significant ones, which relates to weakness of knee extension and hip flexion. You can kind of think of it as like the things you need to kick a soccer ball. You often also get an absent patellar reflex because this nerve often mediates that reflex. And in testing scenarios, the concerning etiology would be a retroperitoneal hematoma compressing the femoral nerve. For perineal neuropathy, it's really compression across the fibular head. You can think about folks that have had a recent weight loss or don't weigh a lot, and they cross their legs, and they'll often get this foot drop. What's important to know, both clinically and for testing circumstances, is that these patients will have poor eversion or outward lateral deviation of their foot, but retained inversion strength, so kind of asking a patient to point their foot or toe inwards towards their midline, and plantar flexion will also be preserved. Those are 2 important features to help distinguish it to the nerve root impingement that relates to this, which we're about to discuss in a few minutes. EMG can help localize these cases, but generally also supportive care with an ankle fixation orthotic or AFO. Again, the patients that are low in weight are at risk for that particular neuropathy. Now, the differential for these kind of lower extremity nerve impingements are the nerve roots. So the nerve roots, as they come out of the spinal cord, can be impinged and cause sensory problems in similar distributions, but there are some key differences to know that are high yield. The L3, L4 radiculopathy also results in a decreased patellar reflex similar to the perineal injury, and you get isolated knee extension weakness. L5, which is also a very common nerve root to impinge, gives you dorsiflexion weakness, but both inversion and eversion weakness, again, helping distinguish it from the perineal neuropathy. And then you get decreased sensation on the dorsum or top portion of the foot. The S1 radiculopathy gives you absent ankle reflex, and it gives you plantar flexion weakness. I mentioned before that plantar flexion was preserved in the previous case of the mononeuropathy. In the case of S1, plantar flexion is weak. That's basically standing on your tiptoes, and you have decreased sensation typically on the bottom of the foot. So having said that, we've got our next audience response question, number 3. A 35-year-old male patient presents with back pain radiating down his right leg for the past week and a half. He has no relevant past medical history. Cranial nerves look good. Motor system, fortunately, is full strength, but he does, on straight leg raise, elicit the typical radiating pain on the right. He gets tingling on the bottom of his foot, and his ankle reflex is absent asymmetrically on the right. So knowing that, what is the most appropriate statement and plan at this point? One of these 2-part questions. So is it A, lumbar strain and conservative treatment, B, S1 radiculopathy and conservative treatment, C, L5 radiculopathy and conservative treatment, D, S1 radiculopathy, confirm with MRI L-spine, or E, L5 radiculopathy, confirm with MRI L spine. Okay. The majority of you answered B, S1 radiculopathy with conservative treatment. There was, a reasonable alternative answer at D with S1 radiculopathy confirmed with MRI L spine. The most correct answer for this particular stem would have been conservative treatment, which we're about to get into as well. And because it was bottom of the foot and ankle, it's more likely S1 than L5 for those that answered C. So for back pain, this type of radicular kind of lumbosacral back pain, the current recommendations are to treat conservatively for a duration of time, at least 1 month, although some people recommend longer to be considered for conservative treatment. However, you would get imaging if certain scenarios present themselves up front, basically your red flag symptoms. The reason for this clinically, beyond just a review board test situation, is because there are a lot of incidental findings on imaging and you don't want that false association, sort of true, but unrelated. But image first scenarios or red flag scenarios include a history of known cancer, in which case an X-ray would probably be the first modality of choice because they show up on X-ray. Multiple risk factors for cancer for similar reasons. Osteomyelitis risk would be better evaluated upfront with MRI, and that includes a history of injection drug use, positive TB screening test for exposure, or other risks. And then any symptoms of urinary retention or fecal incontinence that came up would be a red flag, as well as any progressive motor weakness on exam or by report would be a potential red flag as well. Audience response question number 4. A 25-year-old had a viral URI 2 weeks ago. He now presents with 3 days of progressive weakness accompanied by acute back pain. He has tingling in his feet and absent vibration at the toes. His strength is grade 4 out of 5 of the shoulders and hips, as well as grade 3 out of 5 of the hands and dorsiflexors in the feet. It is difficult to elicit reflexes at all. He has bilateral facial weakness and cannot lie flat as it makes him uncomfortable. His neck flexion grade is 2 out of 5. Which would be the most appropriate initial test to order? A, arterial blood gas, B, lumbar puncture, C, MRI of the lumbar spine, D, forced vital capacity, E, oxygen level, or F, chest X-ray. Okay, kind of a split answer between probably the two most reasonable options. The correct answer, if you will, is forced vital capacity. I will explain why in just a moment, but B is also the most appropriate diagnostic test to figure out what the diagnosis is or confirm it. Of course, what we're talking about is Guillain-Barré syndrome, also known as acute idiopathic or acute inflammatory demyelinating radiculoneuropathy. And so that's why Guillain-Barré is easier to say. Classically, with an antecedent viral URI or respiratory infection prodrome or a history of diarrhea typically caused by Campylobacter, but it can be any kind of infection that precedes it. It is classically described as an ascending symmetric paralysis or weakness. And you can get proximal and distal involvement, but it ascends from the length-dependent kind of way. So typically involves distal more than proximal, but kind of marches upwards. And it classically has areflexia or decreased reflexes. The reason for the sort of so-called best answer being forced vital capacity is because the reason these folks would die more frequently in the past is because of impending respiratory failure and doom, as well as autonomic dysfunction in some patients as well. So forced vital capacity is one component of respiratory tests. Also, negative inspiratory force would be an appropriate measurement as well. But the diagnosis, to confirm the actual diagnosis is correct, is a lumbar puncture or CSF analysis with the classic cytoimmunologic dissociation with elevated protein as well as normal white blood cell count. Also, clinically, these patients first get symptoms of acroparesthesias. That's where the back pain came from, this sort of sense of kind of numbness that will often kind of vaguely radiate to the legs, similar to nerve root impingement, but typically is bilateral. And there can be sensory involvement, despite the fact this is described as a classically motor phenomenon. Now, as far as treating these patients based on the latest practice parameters, IVIG and plasmapheresis are considered equivalent. There's obviously differences in the mode of sort of delivery, and so there's often practice preferences. But for ambulatory patients within 2 weeks onset of symptoms, or for non-ambulatory patients within 4 weeks, we often proceed with plasmapheresis based on this guideline. For patients that just require ambulation aid, IVIG started within 2 to 4 weeks from onset of symptoms is also reasonable. Corticosteroids, though, are not efficacious and not contraindicated, but you just wouldn't give it in this scenario of acute idiopathic demyelinating polyneuropathy. And then IVIG followed by plasmapheresis or vice versa provides no additional benefit. They actually did a study of crossover and it didn't provide a benefit. In addition, theoretically, you're washing out all the IVIG by doing subsequent plasma exchange in that order. Now, its cousin, CIDP, which we do think is a separate disease, but you often don't know which is which when a patient first presents. This is the chronic form, the chronic idiopathic demyelinating polyradiculoneuropathy, an autoimmune neuropathy with more than 8 weeks of progression or relapse. So oftentimes you think it's AIDP and then you realize later it's CIDP. A couple differences include the proximal and distal muscle weakness on exam with more diffuse distribution than with AIDP's length-dependent areflexia. Demyelination is obviously baked into the name. That's what the D stands for. So you get demyelinating features, including conduction blocks on the EMGs, and you get the same elevated CSF protein with that dissociation. Treatment, similar approach, with the exception of steroids sometimes being used for the chronic form, and then oftentimes using steroid-sparing agents, obviously to spare them from the effects of steroids, which includes azathioprine and mycophenolate. This is more of just a clinical schema for you that I developed, and it just talks about the differential diagnosis of generalized weakness presentations, where you can see that if it's nerve root related or nerve related, it has this lower motor neuron pattern associated in nerve roots or polyradiculopathies with areflexia and a dermatomal distribution of sensory loss. And then if it's nerves causing generalized weakness, you're pretty much talking about a polyneuropathy, the most common of which is a distal symmetric polyneuropathy. And that gives you sort of a neurotomal distribution, but a distal gradient of sensory loss. And of course, neuromuscular junction diseases, as well as muscular diseases or myopathies, don't give you any sensory problems, therefore don't give you that pattern. And they also really don't follow a classic lower motor neuron pattern disease because it's obviously not neuron related. Let's see. Okay, so how to approach a general metabolic neuropathy workup. You guys work in internal medicine areas, so this is probably familiar to you. But essentially, if you have a patient who presents with a distal symmetric polyneuropathy, how do you approach the diagnostic aspects of that patient's care? And of course, some form of oral or glucose tolerance test, in this case, the most sensitive being the oral glucose tolerance test. I do know that in the clinical world, people often use the A1C as a substitute, but the classic answer is oral glucose tolerance test. B12, if the B12 is only borderline low and not explanatory, we often still check methylmalonic acid or MMA, as well as homocysteine. But MMA comes up more commonly on testing circumstances. TSH has associations with thyroid-based weakness and numbness, including carpal tunnel, multifocal neuropathies, as well as myopathies. Serum immunofixation because of MGUS could be there, but you also get it if you have any hint towards a hematologic condition such as multiple myeloma, amyloid, or Waldenstrom's. Idiopathic categories, just to point out what you probably already know, is that oftentimes there is no specific diagnosis in these cases, and up to 1/3 of cases. Those cases typically are sensory predominant and quite painful. And then as far as toxic causes, often linked to the exposure, a lot of chemotherapeutic agents cause a painful neuropathy, HIV medications, and of course alcohol is way up on the top of the list. In fact, if you combine diabetes and alcohol epidemiologically, they account for more than half of the cases of distal symmetric polyneuropathy. And then a little bit of a rare case, but high yield for testing circumstances is lead poisoning, which can give you a distal symmetric polyneuropathy, but is most commonly associated with a wrist drop in the form of a mononeuropathy. Okay, now on the differential of generalized weakness, as I said before, there's these myopathies. The most commonly tested myopathies are on these group of inflammatory myopathies. They're sort of combined clinically in that they all give you subacute weakness with an elevated creatinine kinase to a differing level. Dermatomyositis is relatively easy talk because it's the association of these inflammatory myopathies with classic dermatologic findings. Heliotrope rash, Schall sign, kind of these sun-sensitive rashes that occur in the face and neck area, as well as Gottron's papules in the knuckles, and some other classic findings. The pathology, if they end up showing you a pathological slide, which we have to demonstrate to you today, it will show perifascicular atrophy of the muscle fibers. But polymyositis, which is sort of a more controversial collection of non-specific inflammatory myopathies, has inflammation invading the non-necrotic muscle fibers and doesn't have the same perifascicular atrophy as dermatomyositis, and of course, also doesn't have the same dermatological findings. However, and I think this is actually a really good clinical point as opposed to necessarily a testing point, although it probably will come up as well. Dermatomyositis and polymyositis both have a high association with cancers. And so up to 1/3 in the case of dermatomyositis. So one of the things I impress upon anybody working in primary care and internal medicine is to make sure that if this person's in the care of a neurologist, especially, to make sure that the patient's being appropriately ruled out for malignancy. One thing to mention that kind of comes up as a differing feature, obviously a lot of these inflammatory myositic conditions have this proximal weakness more than distal, but there's a condition called inclusion body myositis that is rare, but often used in testing circumstances to show a difference. It is classically in the finger flexors and knee extensors, which are muscle groups that are not as proximal. So this is kind of like an opposite scenario where they actually have a little bit more distal weakness than proximal weakness, at least in some groups. Also, it tends to affect older males more often than females, which is a little bit different when you compare it to dermatomyositis. So testing vignettes often mention males older than 55 that have this condition. It is the most common form of newly acquired myopathic process in men older than 60. The pathology obviously includes these inclusion bodies for which it's named that are kind of in the vacuoles and sometimes even have amyloid deposition. The treatment options or approach to all of these inflammatory myositis are pretty similar. It's steroids, IVIG, methotrexate, rituximab, azathioprine, mycophenolate. In general, the last several are used to, again, spare the person from chronic exposure to steroids. From a prognostic standpoint, this, unfortunately, inclusion myositis does not respond as well to those therapies. Here are just some additional slides. Here's that perifascicular atrophy on biopsy on the left, and then just an example of Gottron's papules in the skin, kind of slightly raised erythematous lesions on the dorsum of both hands. But there, again, there's also Schall sign as well as a heliotrope rash kind of around the eyes. It's classically used. This is sort of a bonus video case. I don't know if this will come up on an exam situation because it represents a fairly rare phenomenon. What you're seeing in the reflex hammer as it hits the thenar eminence or thumb pad is a sort of a prolonged involuntary contraction of that muscle group and a sort of prolonged relaxation that is called myotonia. So if you were to see that on an exam, that's myotonia. Most commonly associated, has several associations, but most commonly associated with myotonic dystrophy, which is the most common dystrophy to affect adults. Most of the dystrophies are pediatric in nature, but myotonic dystrophy is an exception to that. Okay, audience response question number 5. A 67-year-old presents with a 5-month history of progressive weakness. It began with a right foot drop, but has been progressing slowly to other limbs as well. He has atrophy of associated muscles of weakness with some fasciculations. Fasciculations being those small little vibrations of the muscles that if you look close enough, you can see. Deep tendon reflexes are 3+ throughout with upgoing plantars bilateral. What we're saying there is upgoing toes to the Babinski maneuver. So this is like a plantar response. So they actually go up is what that's referring to, which is not normal. He has normal sensation, no ataxia, and no dysmetria. And the question associated with this stem is, which is the best medication management choice? Is it A, prednisone, B, azathioprine, C, pyridostigmine, C, creatine, or E, riluzole? Okay, the majority of you answered ribosole, which is the correct answer. This stem, I think, is kind of complicated, and so there's a little bit wider spread of answer choices here. What that case was trying to elicit was motor neuron disease, probably and unfortunately ALS, or amyotrophic lateral sclerosis, the most infamous of motor neuron diseases, also known as Lou Gehrig's. The clues in the stem to know what that was the clinical features of motor neuron disease is the presence of both upper motor neuron signs and lower motor neuron signs, not only in the same patient, but also often in the same limb or group, like face. So the fasciculations that were mentioned, again, those muscle twitches, are more commonly associated with lower motor neuron injury. Atrophy actually is more commonly associated with lower motor neuron, at least early stages. You can get atrophy with upper motor neuron injury, but it's usually a late manifestation. So when you hear atrophy, certainly severe atrophy, as well as fasciculations, you tend to think lower motor neuron. And when you see hyperreflexia, which that patient also had, the upgoing toes, the 3+ reflexes, and in some cases you can even feel rigidity or hypertonicity, those are all features of upper motor neuron injury. And so the presence of both, certainly in the same limb or groups, makes you start to think about motor neuron disease. And again, the most infamous being ALS. There are other forms. Generally, the features are not good prognostically, obviously. And the only FDA-approved treatment for ALS is riluzole, making that the correct answer to that question. The only other thing to say is that, it is a terrible disease for many reasons, but one of the terrifying reasons for practitioners is that it's primarily a clinical diagnosis. So the ability to make this terminal kind of diagnosis is basically on us. There are supportive things that you can do to try to make sure it's not a mimic, but by and large, it's a clinical diagnosis. So important to know those things, both clinically and for your examination. Okay, but switching gears to audience response number 6, 47-year-old male presents with vertigo to your office or dizziness. This has been going on for a week, so it's acute. He describes multiple discrete bouts of an intense room spinning sensation multiple times per day. The attacks lasting only about 15 seconds at a time and generally triggered by standing up or looking to the left. He has a past medical history of lupus. He's on hydroxychloroquine, and his neuroexam demonstrates no dysmetria or ataxia. So then the question is which treatment is the most likely to be effective in this patient? Is it A, salt restriction, B, prednisone, C, canalith repositioning, or D, aspirin? Okay, wow. Excellent. Well done, everybody. So the correct answer is C. Canalith repositioning maneuver is the correct thing because what we're dealing with in that scenario is benign positional paroxysmal vertigo. So again, the classic description of that is brief, generally seconds of positional-based vertigo, in which case the diagnostic maneuver is the Dix-Hallpike, and you actually just could complete that maneuver to make the Epley maneuver and actually treat them. And it's so lovely to have a bedside treatment for neurology, believe me. There are some others, if you're interested clinically in this topic, there are some other maneuvers, including the somersault maneuvers, that can work when the Epley maneuver fails. And so I encourage you at some point in the future to, YouTube other maneuvers for benign positional vertigo if that's helpful to your patients. Oftentimes, the clinical question, though, is it something benign or something not so benign? And so at the top of this slide, it talks about things that make you concerned for a central cause. This could be a lesion, most likely a stroke in the brainstem or cerebellum that would give you to kind of split between this is something benign that I don't need to worry about in particular, or this is something very concerning. That includes nystagmus or eye jerking in all directions or more than one direction. Certainly vertical nystagmus is almost always concerning, or at least somewhat concerning. And then nystagmus that doesn't extinguish. So most nystagmus that's benign will actually be very severe, but then slowly get better. Certainly if they have focal deficits on neurologic exam, that's kind of an automatic concerning thing, I would think. And those include cranial nerve abnormalities because we're talking about the brainstem. And then any cerebellar findings would be concerning as well. That's why our patient didn't have dysmetria and ataxia, is that this is sort of an inner ear problem. And although if you do advanced exam techniques like the Dix-Hallpike, the neuroexam will be abnormal, but your standard neuroexam won't detect it unless it's a cerebellar pathology. Differential diagnosis for this, including other benign causes or peripheral causes, I should say, includes labyrinthitis or neuronitis. This is basically inflammation of the labyrinth or the actual eighth nerve. The differences often relate to the time course or duration. So it is still acute and has significant vertigo, but nausea and vomiting often last several days, and it has sort of a slower resolution to normal in that time course. Often people talk about Meniere's. That is episodes lasting usually hours, and you often get hearing loss, tinnitus, or sort of a fullness in your ear. And that's where salt restriction from the previous question would have been the correct answer had it been Meniere's disease. And then acoustic neuroma is basically, again, kind of a benign-ish tumor, depends on your definition of benign, but it certainly doesn't metastasize, but a tumor of the nerve that can cause hearing loss that's a little bit more permanent, tinnitus and unsteadiness and tilting, because it can involve the corner of the cerebellum and can make you veer in one direction. Okay, audience response number 7. 73-year-old female presents with tremor. This has been progressively worse over the last 6 months. On exam, you notice some mild increased tone of the extremities and decreased arm swing during the gait evaluation. No family history of tremor. Rest of the exam is non-focal. The patient states that she's had a tremor of the head too, but you just notice a chin tremor on examination, and we do have a video upcoming in just a second. Past medical history includes high blood pressure, diabetes, hyperlipidemia, osteoarthritis, and a history of myocardial infarction. Family history, again, is no family history of tremor, but does have cancer and heart disease. And we have this tremor right here. So this video, hope you can appreciate it from the audience there, but what we have is a tremor that's kind of moderate to large in amplitude. It briefly got better when she moved her hands, but now that she's stationary again, it kind of came back. And again, it's sort of coming back again, reemerges as she rests her arms, her hands. And it's sort of, maybe the frequencies around 2 to 4 hertz. You know, again, it's bilateral but asymmetric. And here's the chin tremor that was mentioned. I will mention why it's important to distinguish chin tremor versus head tremor. But the question associated with this stem is, which would be the most effective medication for this patient? A, propranolol, B, primidone, C, clonazepam, or D, carbidopa, levodopa? Okay, excellent. The majority of you got this one correct. This was a tremor that was more classic for Parkinsonian tremor, and so it was trying to lead you into the Parkinson's disease category, hence I think the rigidity on examination as well as problems walking. So to talk about sort of tremor, we'll also talk more generally about Parkinson's disease, but this case was kind of presented as a tremor predominant issue. And so talking about tremor, the Parkinson's disease tremor is typically worse at rest. Patients will also have bradykinesia or slowing of movements, posture instability, and rigidity, which our patient in that stem had. They usually respond very well, at least in early stages, to dopaminergic therapy. Now, again, kind of circling back just to the presentation of tremor, the 2 major categories of tremor, and there are certainly more. In fact, we'll mention the third most common here. But the difference between Parkinsonian tremor and essential tremor. Essential tremor, in contrast, is more postural, so worse with action or sustained posture. So when she raised her hands up, it actually would have gotten worse immediately. And you also get a prominent head nodding tremor. For those that remember Katharine Hepburn's late work, she had a classic head tremor associated with essential tremor, and that was what gave her kind of her classic, not stutter, but classic tremulousness in her voice, often associated with a family history or improvement with alcohol as clues to that diagnosis. And the treatment paradigm is certainly different. When you usually treat with propranolol or primidone for those severe essential tremors. And again, there's no other Parkinsonian features on examination is another clue to the essential tremor question. And then one of the more common tremors is a drug-induced tremor, which can actually have multiple presentations. It can look like an essential tremor, or it can be a little bit more finer in amplitude, lower in amplitude and higher in frequency, often bilateral and worse with action. There are actually tons of drugs that can do this, but in my world, they often quote the neuroleptic medications or a lot of CNS acting medications, and then antiemetics such as metoclopramide. Okay, and in Parkinson's disease, clinically, these are rare conditions, although they are great fodder for examinations. There are conditions called Parkinson's plus syndromes, which, as the name might imply, present with a lot of Parkinsonian features, but then also have additional features to clue you in to the diagnosis. Progressive supranuclear palsy is Parkinsonism with a profound vertical gaze palsy, meaning when you ask these patients typically to look up, they have a difficult time doing that. Turns out they also have a difficult time looking downwards, but that's kind of more a natural resting state, so they don't often complain of that. They often have early falls compared to Parkinson's patients because they have an inappropriately fast gait and inappropriately fast turns. They kind of take those turns a little too fast. So they often have more prominent falls in their history. Multiple systems atrophy has several subtypes, the most common of which is the autonomic subtype, formerly known as Shy-Drager syndrome, but they've gotten away from that eponym probably for good reasons. But essentially, that is Parkinsonism with profound autonomic features, including really severe orthostatic hypotension that is very difficult to treat. There is a cerebellar subtype. I had mentioned that patient didn't have ataxia or dysmetria specifically, but an MSA-C or cerebellar subtype, they can get those features as well. Then lastly, probably most rare but most bizarre is corticobasal degeneration, which you get very asymmetric symptoms, often unilateral. Parkinson's disease is often a bilateral disease that is asymmetric. This is a unilateral disease that gives you alien hand phenomenon or neglect to the point where your hand kind of acts independent of your conscious thought and cortical sensory loss. Also in the differential for at least gait instability and dementia is normal pressure hydrocephalus, which gets a lot of press. Normal pressure hydrocephalus is that classic triad of cognitive dysfunction or dementia, incontinence, which typically is in the form of urge incontinence, and gait apraxia, which really results kind of clinically as a complaint of slowing of gait, similar to Parkinson's disease, which is why it's here. Now, other movement disease or movement considerations, certainly in the wheelhouse of internal medicine, probably covered an overlap and duplication in other areas as well, is neuroleptic malignant syndrome and serotonin syndrome. The reason they're here is because they often have common feelings of rigidity. And so that can, as you approach Parkinson's-like patients with rigidity, it's important to ask them about taking these medications because they can mimic that scenario as well as other things. So in neuroleptic malignant syndrome, you get the rigidity, but the triggers include, of course, neuroleptics, but antiemetics as well, or rapid withdrawal of Parkinsonian medications in those with Parkinson's disease. Your treatment is supportive care, of course, decreasing the offending agent, and then considering dantrolene, bromocriptine, amantadine, or in the severe cases, ECT. I see dantrolene most often mentioned sort of in the testing environments. Serotonin syndrome includes hyperreflexia, tremor, and clonus. So a little bit different presentation, but can also have profound rigidity as well. Triggers are often, as you imagine, serotonergic medications like SSRIs, MAOIs, TCAs, SNRIs, but even tramadol, dextromethorphan, cocaine, amphetamines, and triptans. And certainly co-use or any combination of these is something to avoid. To treat this, you want to decrease the offending agent, supportive care, and then most commonly, medication used is cyproheptadine. Sort of a little bit, grouped into this movement disorder, it probably wouldn't be the same complaint, but restless leg syndrome, most often presenting either as a direct complaint about the restless legs or poor sleep quality or sort of sleepiness and drowsiness during the day. Restless leg, though, is technically a movement disorder. The things to know about this is it classically presents, again, as like poor sleep, tiredness during the day, but they will often describe this discomfort in their calves or feet that is particularly relieved by getting up in the middle of the night and walking around, is kind of the classic description. What to know about this is that sometimes it's due to iron deficiency, and that's a nice reversible cause, so something not to forget. It's not always the most common cause, but it's important to check iron, ferritin, and TIBC in those patients, because that'd be nice win if that ends up being the cause. If not, oftentimes we treat these patients with dopamine agonists, which have their own share of potential side effects, including a rare disinhibition syndrome, which is important to know clinically. Audience response question number 8. kind of switching gears a little bit. A 26-year-old male presents to the ED with a severe ongoing retroorbital stabbing headache times 40 minutes. He has awakened from sleep at 2 a.m. for 5 days in a row with similar headaches lasting about 1 hour. He's had similar episodes for about 3 weeks last year. Medical history and family history were negative or non-contributory. Medications include just a multivitamin, and on neuroexam, there are no deficits. There is no papilledema or disc edema in the back of the eye and no nuchal rigidity. So the question here is, which of the following is the most appropriate next step in patient care? A, 100% high float oxygen through a mask. B, propranolol. C, prednisone taper. D, verapamil daily. E, lumbar puncture. Or F, trial of indomethacin. Okay, great. Yeah, you're right. The correct answer is A, 100% high float oxygen through a mask, and the majority of you got that correct. There are some clinical caveats here. I think the important point here is that it is 100% in high flow through a mask. The concentration I'm often asked in the hospital, is the nasal cannula on the wall enough? And the answer is no, it's really got to be high content oxygen. And it's only really beneficial in the hyperacute stage. So it's really something that's probably better administered at home. And so it is the abortive treatment of choice for cluster headaches, although there are some other options in lieu of high flow oxygen, which might explain some of the other answers, which might be reasonable. Verapamil daily is the correct answer for the right prophylactic therapy of choice in patients with cluster headaches. So on that note about primary headaches and the differential diagnosis therein and kind of the differences, we'll start with the most common, tension headache. As you guys probably, most of you have experienced tension headaches at some point in your lifetime, is a dull band-like headache that's described as relatively mild or moderate compared to the others, and is typically bilateral. It may be indolent and kind of, it's hard to nail down when it started and when it stopped, typically worse at the end of a long workday. Migraine headache is more of a pounding, throbbing quality with nausea, sometime accompanying that, as well as potential vomiting. And then plus or minus photophobia or phonophobia, typically unilateral or bilateral asymmetric and lasting several hours, which is one of the bigger differences in these different headache types. Then there's cluster headache, which was what the stem was about, a boring stabbing pain with a slight male predominance and autonomic features like lacrimation and tearing that come along with it. Alcohol can also be a trigger, typically unilateral or behind the eye, and can last a very unfortunate long time, often following a circadian rhythm. So people will classically report around 2 a.m. having the start of a headache, waking them out of sleep. It is clusters in that time frame and can happen several days in a row, but also has more of a macro cluster pattern where patients will often get it like once per season. Hence that in that stem, the patient had it at a similar time of year. So it clusters kind of in the daily clustering aspect of it, but also more on the seasonal clustering. And then trigeminal neuralgia is on this list, a very terrible disease of inflammation of the trigeminal nerve, described as a severe lanzinating pain. I mean, just excruciating. It's terrible to see these poor patients, often with a distribution of V2 and V3, the cheek and the chin area, lasting a few seconds, generally triggered by touch. The treatment's obviously very different. For migraine headache, you've got your abortive therapies and your prophylactic therapies. The prophylactic therapies usually quoted as being beta blockers, calcium channel blockers, or in some cases neuroleptics like topiramate. In addition, TCAs like amitriptyline and nortriptyline on the list as well. Cluster headache can be kind of treated similarly, although often verapamil specifically has more evidence than others. So verapamil is often the right answer for prophylactic therapy of cluster headaches, but otherwise approached in a similar fashion to migraine headaches. And then trigeminal neuralgia, the most often quoted or studied treatment therapy for it, there are several, is carbamazepine. So the most often tested one is carbamazepine for that disease. And often the question is, well, is it a benign primary headache or is it a terrifying secondary headache? And these are just some examples of some of the scarier causes of secondary headaches. Idiopathic intracranial hypertension, what was previously known as pseudotumor cerebri, now known as IIH, typically affects young overweight females with transient visual obscurations. That's what TVO stands for. These transient kind of visual phenomenon, like often are positional because of the pressure. And so they just describe this kind of dimming of vision that can be very transient and TIA-like in their nature. It can be a herald of potential permanent vision loss, so it is an important disease to recognize. They will sometimes also get double vision from the same pressure phenomenon, pulsatile tinnitus with their heartbeat, and obviously disc edema associated with it. Etiologies include toxic levels of vitamin A, tetracycline use, growth hormone, Behçet's, lupus, and polycystic ovarian syndrome are kind of high yield associated diseases with this condition. Treatments include acetazolamide or furosemide, basically diuretics. ONF stands for optic nerve fenestration. Pretty wild, but it's just like what it sounds like. The sheath around the optic nerve is actually fenestrated or sort of diced to relieve pressure around the optic nerve, which is where this visual loss comes from. So it's only preventative for the vision loss, does very little for the actual headache. Therefore, shunt is kind of a more definitive surgical therapy for that condition. Intracranial hypotension, not necessarily the opposite, but kind of like that, where the pressure is lower and the brain actually kind of sinks, pulls on the meninges and related structures and causes a postural headache, generally considered post-lumbar puncture as a complication of that. You often get this diffuse dural enhancement that can look a lot like meningitis, except for the fact that it's really smooth, kind of diffuse dural enhancement as opposed to lumpy. It does result in low-lying cerebellar tonsils, but again, just because the whole brain is starting to sit lower. Treatments include fluid management. IV caffeine has been known to help and seal up the leaks, but if it doesn't work, you can do a blood patch where you actually squirt a little bit of autologous blood into that area where the leak is, and it seals it up, kind of like crazy glue. It's quite wild. Cerebral venous thrombosis, another important one to recognize. This is stroke, but basically of the venous system as opposed to the arterial system. It causes backup and therefore headaches with the increased intracranial pressure. Altered mentation is sort of a common thing that you wouldn't see in a lot of primary headaches. Focal deficits, obviously on exam, very concerning. Visual changes, seizures are often associated with this as opposed to other ones. This is because they often have either microbleeding or more overt bleeding in the brain from the backup of the pressure in the venous system. And what's why, well, so the peripartum period and hypercoagulable states are the risk factors for this, including hormone replacement therapy. And the treatment, which is wild to try to convince people of this if there's any brain bleeding, but is anticoagulation. Usually, sometimes even high dose protocols. Carotid dissection can cause headaches sort of via association. This is dissection of the carotid artery causing cervical pain radiating to the eye. Usually you get a vignette that talks about antecedent neck trauma. It can be mild in real life. We've had cases where people sneezed real hard and got carotid dissections. This can also classically occur with chiropractic neck manipulation. It gets a lot of press. Actually is a rare phenomenon, but a non-zero phenomenon. So take that as you will. Often associated with a Horner syndrome. So one of the tip-offs on any given vignette will be a comorbid pupillary problem consistent with the Horners on the same side of the headache. This is a common cause of stroke in young people, and the treatment is antiplatelet therapy or anticoagulation. Then lastly is temporal arteritis, very important one to recognize, especially in patients older than 55, because it can result in permanent irreversible vision loss, often associated with a high ESR. In fact, if you have a normal or near normal ESR, it makes this diagnosis very unlikely. They often have associated jaw claudication as well as actual tenderness, and sometimes you can visualize the temporal artery in the side of the forehead there. Often associated with polymyalgia rheumatica, kind of a high yield diagnostic association for tests. And you want to do a temporal artery biopsy is the right answer, but taking that a little further clinically, just make sure if you're in this scenario that you advocate for a very large biopsy because this disease can actually skip portions of the temporal artery and you can get false negative results if the biopsy is not adequate enough. And so if your clinical suspicion is high, you might still want to treat with high dose steroids to save their vision. It can occur bilaterally in sequence too. So sometimes if you've unfortunately missed it on the first go around, you don't want to miss it the second go around. Subarachnoid hemorrhage kind of deserves its own slide as a secondary cause of headache. And most of you are familiar with subarachnoid hemorrhage as the most concerning cause of headache. There are some rules that help guide us about our level of concern for subarachnoid called the Ottawa rules. If patient's younger than 40, there's no thunderclap kind of sudden onset description, no witness loss or alteration of consciousness, or neck pain or meningismus, you're much less concerned for subarachnoid. We often evaluate it with CT. In modern times, with the CTs that we have, you're going to catch 99 point something percent of all subarachnoids. One of the key clinical features to know is that if you actually get it too quick, in a way, I hesitate to say too quick, but in the hyperacute phase, you actually have a higher rate of false negative results from CTs. So one piece of advice is that if you have a high clinical suspicion, is just repeat it in about an hour. But LPs can be a secondary supporting diagnostic test if your suspicion remains high for aneurysmal subarachnoid, in which case you're looking for xanthochromia, which means yellowing of the CSF, which would represent lysed red blood cells prior to the tap. If present, you evaluate for the underlying aneurysm, and you're going to treat delayed vasospasm. They call it delayed cerebrovascular ischemia due to vasospasm now at days 14, all the way from 4 to 14. So it can be quite a delayed response, and you assess for SIADH or hyponatremia. Audience response number 9, a 34-year-old male comes into the ED due to severe pain radiating from the flank to the groin with hematuria. He has a history of epilepsy, and he has been seizure-free for over a year. On the neuro exam, there are no deficits. Which seizure medication is the patient most likely taking? So more of a side effect question. Is it A, levetiracetam, B, pregabalin, C, lamotrigine, D, gabapentin, or E, topiramate? Great, excellent. The majority of you got the correct answer. A common unfortunate idiosyncratic side effect of topiramate is precipitation or worsening of kidney stones, which is what this clinical vignette was getting at. There are very significant side effects to the other medications, which I think deserve mentioning here, some key side effects. Phenytoin is gingival hypertrophy, so people often have bleeding gums with prolonged use of phenytoin. Chronic ataxia is one in my practice that I'm an epileptologist by trade, is concerning because there's a progressive irreversible cerebellar degeneration similar to alcohol's effects over time that can occur. And this is an enzyme-inducing medication, so we worry about osteoporosis or early onset osteopenia and osteoporosis. Carbamazepine, the most concerning thing is hyponatremia. We typically start to get away from this medication if they develop hyponatremia. It is kind of unclear the clinical significance of this, just on a clinical note, because they can have numbers that would be associated with terrible consequences in other diseases that cause hyponatremia, but patients aren't nearly as symptomatic or even asymptomatic at similar levels when it's iatrogenic like this. Because oxcarbazepine is a cousin to carbamazepine, easy to remember its side effects, which is hyponatremia. Topiramate, as we mentioned, can precipitate kidney stones, so it's important to screen patients for a history of kidney stones when going on this medication. They can have an involuntary weight loss, which can be a benefit in some patients, but some patients do not desire weight loss, and so that can be a problem. They do get a benign distal paresthesias that mimics a distal symmetric polyneuropathy. It's not progressive, so I just warn my patients, because you can imagine taking a new medication and all of a sudden developing numbness would be a concerning sign. So I typically warn them about that. And then the most problematic portion of topiramate, probably not testable, but really clinically real, is a cognitive difficulty that's really word finding, almost bordering on aphasia, a word finding aphasia with topiramate. They kind of feel dumb. Levetiracetam, often quoted as being relatively side effect free, not so true. About 10% of patients can develop a limiting or disabling level of mood problem, typically irritability or agitation, and in worst cases, florid psychosis. So for patients with a history of mental illness, levetiracetam may not be the right first choice. Valproic acid has a lot of problems. In fact, if you're in the mode of guessing on the test, valproic acid is not a bad guess. It causes weight gain, hair thinning, tremor, thrombocytopenia, hyperammonemia, even some hepatotoxicity, and obviously is the most teratogenic of all the anti-seizure medications. They all have a non-zero risk of major deformations of children for pregnant women that are taking these medications, but Depakote is by far the worst. Lamotrigine is most significant for a rash that it can be so severe it develops into a Stevens-Johnson syndrome. It might be hard to test that because so many of these can cause Stevens-Johnson's, but that's clinically what we worry about most with lamotrigine. Then finally, lacosamide, one of the newer medications in the market, can cause diplopia, vertigo, and emesis. It also can cause, to a lesser extent than levetiracetam, a little bit of mood irritation and dysphoria. So something just to know in your clinical practice that it can cause some dysphoria as well. I typically don't give it to older patients who already have balance issues because of its issues with balance. Okay. Because this is my area of expertise, I'll try to make sure I don't overemphasize and spend too much time in these slides. But for the evaluation of first seizure, where you guys might encounter these patients on tests or in real life, you want to do, of course, do an H&P. You want to do your basics because there are some provoking factors in a basic metabolic panel, LFTs or tox screen, that could do this. You only do really an LP if encephalitis signs like fever are already there. You would want to do imaging at some point. It's not urgent, like out of the ER, but between then and the clinic appointment, you want to get imaging with MRI because there are some lesions that CT will not capture. An EEG is reasonable, although a normal EEG does not rule out epilepsy. We have plenty of patients who subsequently been proven to have epilepsy who had a lot of normal EEGs in their history. The EEG can be thought of as a 20 or 30-minute snapshot of their brain waves and therefore may be negative. So don't take that as a negative diagnosis. There's an increased risk of recurrent seizures after the first one if it's unprovoked and the EEG is abnormal, hence that's why we do it. There's prior neurologic injury. There's a family history of seizures. Certainly if there's an abnormal MRI that has a culprit lesion, hence that's why that's on the evaluation list. And there's a risk of recurrence after 2 seizures goes up to 60% and is only 35% after the first seizure. So what this boils down to is sort of a coin flip after a first unprovoked seizure. So I typically try not to treat preemptively after a first seizure, but if they have a second seizure, really their probability goes up to justify at that point treatment. Generally, second seizure after a 24-hour period. For acute seizure treatment, you give IV benzodiazepines as the first line. The second line, if the seizure continues, is loading with an IV medication. The most well-studied are phenytoin or fosphenytoin. Alternatives now include FDA approval for valproic acid IV as well as levetiracetam. Fosphenytoin, the reason it's used or preferred over phenytoin is that there's an infusion site necrosis that occurs with rapid infusion of phenytoin. That's why there's fosphenytoin was made, and there's also less cardiac arrhythmias associated with that. If you go into phase 3 of status treatment, and this is not stopping the seizure, you're talking about a rapid sequence intubation to then give sedative medication. And then you might want to get an EEG if they don't bounce back in the appropriate time frame. Chronic treatment, again, after 2 unprovoked seizures. Again, you might consider treatment early after 1 single seizure if there's a focal finding on EEG or on MRI. Some people do it if it's a real prolonged first seizure, if there is a critical social reason, like their job would depend on regaining driving privileges after a first seizure. And again, the data would actually probably support around 4 months actuarially for driving accidents. Most states have either chosen a time frame or allowed practitioners to choose the time frame individually. I used to work in an environment where it was 6 months. Some states are 12 months. Colorado, where I practice, leaves it up to the provider. So most providers have a minimum of 3 months. But if you work in a certain state, you might want to check into what the driving laws are after a seizure, even including a first seizure. Okay. Anti-epileptic drugs that reduce the efficacies of OCPs. A lot of pharmacology will come up on testing environments, and so it's important to know some of these high-yield facts about anti-epilepsy medications, including those that reduce the effectiveness of birth control pills. This includes phenytoin, phenobarbital, carbamazepine, topiramate of the newer medications at higher doses, felbamate, and oxcarbazepine. Note that estrogen OCPs can decrease the levels of lamotrigine. So again, there's kind of a very complicated interaction between lamotrigine and OCPs. Important because lamotrigine is my medication of choice for women of childbearing age because of its high level of study in pregnancy. So getting to that point about AEDs in pregnancy, you can look at this risk of major congenital malformations for children who are born of women taking these medications. Include valproate at 9%, phenobarbital at 6%, topiramate at 4%, carbamazepine 3%, phenytoin 3, levetiracetam 2.4, and lamotrigine 2. So what you can see via this new registry is that even the newer medications, which are safer, are still not zero, and certainly above the baseline risk of having these major congenital midline malformations. So if a woman is on this, you try to get them to monotherapy on reduced doses with frequent level checks, because if you can reduce that based on levels, all the better. You want them to see a high risk OBGYN, certainly. And I think there's one other point I was going to make. You want to avoid valproic acid, obviously, if you can. The worst thing for a pregnant woman is probably having seizures. So when it comes down to being on these medications, it's the right thing to be on them, but you try to modify it as you can. Okay, a quick note about psychologically induced non-epileptic seizures. The most recent PC name for this is just non-epileptic seizures. It does go through name changes every once in a while. I do like for people taking tests to be aware of all the different names, just in case the tests lag behind the most appropriate terminology. So we call it non-epileptic seizures now. In the past, known as non-epileptic events, non-epileptic spells, psychogenic non-epileptic seizures and spells. Pseudo seizures is a very common name for it in the past. They're basically seizures, but not due to abnormal brain activity. And these are some suggested features. You want to order a video EEG if suspected. What's wild is that a lot of people have both, and so you can't always just sort of assume it's all non-epileptic seizures in those patients. The differential diagnosis for seizure, as you guys can imagine, includes syncope. There are, as you guys probably are familiar with the differences between the two. I like to also talk about the areas of overlap, as that often comes up. You can get post-convulsive syncope, a really bad syncope that results in poor blood flow, can result in brief jerks of the arms and legs. That often is referred to me, and it's likely post-convulsive syncope. However, on the flip side, there are some rare seizure types that cause cardiac arrhythmias and can kind of mimic syncope. So of course, it's quite soupy in the real clinical world, but the major differences are that seizures can either have an aura or no warning, whereas syncope gives you that classic lightheaded, pallid kind of presentation with palpitations, chest pain, or little to no warning. The ictal phase, really the timing is key. It's really hard by witnesses because when a loved one's having either one of these things, it can feel a lot longer. But the ictal phase for seizures are typically 1 to 2 minutes with self-resolution, and the sort of ictus or striking phase of syncope is very, very brief. And then with seizure, you typically take several minutes to sometimes hours to recover, whereas syncope, there's usually no post-ictal or prolonged post-ictal state. Ischemic stroke, acutely, you do your ABCs is always the right answer to how to approach stroke initially. Doing a modified neurologic examination, for those that are familiar with the NIH stroke scale, is the sort of protocolized version of the neuroexam that you do in the setting of acute stroke. You only treat hypertension if it's extraordinarily high, way beyond our usual comfort level for high blood pressure, and you want to bring it down slowly because of the autoregulation mechanisms in the brain. For TPA candidacy, for IV TPA candidacy, you want to be at a blood pressure below 185/110. So we try to lower that slowly from those higher levels to that level so they're a better candidate for intervention. You get a non-contrast brain CT acutely, levels of coags, CBC, and glucose. It's basically your acute stroke protocol or stroke alert. The newest guidelines from the Stroke Association talk about this is IV thrombolytics or IV TPA. The best candidates are those with a higher stroke score above 4. However, I will say clinically, we certainly still advocate for its use even in mild numbers. Just because the number's low doesn't mean they don't have a profound deficit on exam. Again, it's acute ischemic stroke in less than 4.5 hours. That changed from the kind of previous round 3 hours to include patients in a 4.5-hour window. Basically, there's a subset population that you do in that 3. The old recommendation from 3 to extension 4.5 is those that are, you exclude them if they're greater than 80, have severe diabetes, prior ischemic stroke, using anticoagulation, or a very large stroke scale indicating probably a large stroke that's more likely to bleed in that time frame. And again, blood pressure can't be more than 185/110, so it's stricter in that extension time frame. There's no absolute TPA exclusion criteria. That's just a point to make that it's really a case-by-case sort of consideration with those guidelines, but those are relative contraindications. The update includes a lot of updates regarding endovascular therapy, which you probably, if you're at all kind of in this world, have heard about over the last several years. There's been a lot of developments in our understanding of the efficacy of endovascular intervention acutely in acute ischemic stroke. Basically, if you have an occlusion of the ICA or the proximal MCA, so it's really kind of artery specific where the clot is, the labeled use of this intervention is in adults, although they're off-label sometimes uses in pediatric populations. Typically, you want to score it's a little bit higher because they're most likely to benefit from this intervention. There's something called an aspect score, which is an imaging-based score. The radiologists are very familiar with this. They're looking at basically how much savable brain there is by looking at the acute radiology to say this is a good idea. There are actually now even more emerging trials reconfirming the efficacy in different subpopulations, but DAWN and Diffuse 3 trials were pretty remarkable, looking at the extended window for mechanical thrombectomy, extending all the way out to 16 to 24 hours for large vessel occlusions. Again, ICA or proximal MCA. And I think that the important message here is that really time still is brain, that hasn't changed, but the ability to intervene on these patients in a more aggressive way or more intense way has been really extended. So you don't want to rule somebody out of potential intervention if they're outside of that typical 3 to 4.5 hour window that we've been talking about for so long. As far as then secondary prevention or what to do after that point, aspirin or combination or clopidogrel monotherapy is the right way to approach it. A lot of times they haven't really showed different efficacy between these three. It's really a tolerance issue with aspirin and ER dipyrimidol, easy for me to say. And obviously clopidogrel is a little more expensive, so often people turn to aspirin first, but one of these therapies is the right way to do it as monotherapy in most scenarios. What's emerging, or more recent, is combination or dual antiplatelet therapy. Obviously, we use that in other areas like in cardiovascular medicine, but in stroke, that really hasn't been used or wasn't encouraged until recently in certain cases of intracranial stenosis. So it was found that actually stroke prevention and the data would actually maybe advocate even just for the first few weeks after a stroke to do a dual antiplatelet therapy if it's due to intracranial stenosis. The trials ended up using 90 days, but it turns out the data might even show that it's a shorter window and that after that point, you only have increased risk of bleeding complications. But the official answer is 90 days for test-taking purposes. Anticoagulation indications beyond just the antiplatelets include, of course, AFib as being the most common indication. If you have an L3 thrombus with a resultant STEMI would be another one. A DVT with a PFO, prosthetic or rheumatic valves, sinus venous thrombosis. The data is not as robust in these conditions of arterial dissection, low cardiac output due to ejection fraction being low, or hypercoagulable disorder is more case by case. There's no anticoagulation for embolic stroke from endocarditis. And this kind of makes sense. The endocarditis, the right treatment is the IV antibiotics. It turns out, for whatever reason, the strokes that result from endocarditis are actually more likely to bleed, and that was just discovered via experience. And so there's really no role either for antiplatelet therapy or anticoagulation if the embolic stroke is clearly due to bacterial endocarditis. You also want to use high-dose statin treatment. There's not only the lipid-lowering effects for secondary prevention of stroke, there actually been via this something called the Sparkle trial, they showed there's might be an anti-inflammatory component or anti-vasospasm component to high-dose statin. You want your blood pressures to be appropriately low. After the 48 hours is when your autoregulation usually resets after ischemic stroke, so you want to go back to target after that point. And then carotid endarterectomy, or stenting in less cases for those that have stenosis that's greater than 70%. It should be done within 2 weeks, and the surgical risk should be less than 6%. So some patients with high surgical risk are kind of ruled out from carotid endarterectomy due to carotid stenosis causing symptoms or stroke. Hemorrhagic stroke, often dealt with by the neurosurgeons, but if it's parenchymal hemorrhagic stroke, not subarachnoid, It's often just supportive care early, your typical ABCs. We try to do some mediating measures to decrease intracranial pressure, which means head of bed is slightly elevated at 30 degrees, optimizing glucose, treating fevers, treating seizures, which can increase ICP, and then monitoring for ICP, or again, increased intracranial pressure, looking for any hydrocephalus concern or secondary problems. And then blood pressure management, generally you want to have a target BP of 160 or a centralized pressure of 61 to 80 if you're concerned for elevated ICP. And then surgery and intracerebral bleeding basically is reserved for cerebellar hemorrhage greater than 3 centimeters. That area of the posterior fossa is just a tighter bony compartment, and so the risk of herniation is so much higher in that area. And then if you have clinical deterioration or hydrocephalus, that's a reason to go and do these interventions. If it's supratentorial or above that tight area, you do a craniotomy for lobar clots greater than 3 cubic milliliters or within 1 centimeter of the surface. It's best if they're younger, kind of makes sense, and considered best with the intermediate level of consciousness. So it's kind of like you don't want their prognosis to be too bad, but also too good for this particular craniotomy or decompressive surgery. Basic stroke localization. Obviously, I could spend an entire hour just talking about localization in neurology, but I do think there are certain kind of cheats that you can use to kind of quickly identify where the localization might be. Dominant MCA, so the dominant side means language, so you're looking at the contralateral face arm weakness more than leg weakness with aphasia, so language problems. Non-dominant MCA is kind of the same, but with neglect instead of aphasia. Neglect typically is on the left side. You typically neglect the left side of your world with a right-sided stroke. ACA territory is the opposite, where you get more leg weakness, that old homunculus drawing of where the weakness comes from in the cortex. Lacunar infarcts are a little more subcorticals. They typically involve a distribution of contralateral face, arm, and leg in a more even distribution, as opposed to the ones above where you get more arm than leg, etc. Thalamic strokes are kind of interesting. You get contralateral sensory problems, what they call the thalamic pain syndrome. Very terrible pain syndrome, using the opposite side of the body after the stroke is done. Brainstem, very complicated place, always vexing for my medical students. The way I kind of simplify it is that if you get a vignette on a test that has crossed findings, left this and then also right that, plus cranial nerve deficits that are written out on the vignette, it's probably brainstem. There are exceptions to that, of course, but that's a simple rubric. And then cerebellum is you get ipsilateral or same side dysmetria. That's that finger to nose testing where it starts to go a little wonky towards the end. Okay. Audience response question. A 59-year-old male presents with fever and sepsis. His blood cultures are positive for Staph aureus. On day 2 of the hospitalization, he develops right-sided weakness and aphasia, is found to have an acute left MCA stroke. Echo reveals a valvular vegetation consistent with endocarditis, providing a mechanism for embolic stroke. I think I may have given this one away. But the question is, which is the best course of treatment? A, antibiotics and clopidogrel. B, antibiotics and heparin. C, antibiotics only. D, high-dose steroids. E, high-dose steroids and antibiotics, or F, high-dose steroids and heparin. Okay, great. And the majority of you got the right answer. And again, it comes from before in that antibiotics are certainly a component of the correct answer, but antiplatelets or anticoagulation has little to no role because we discovered, actually before my time, they discovered that for whatever reason, when this bacteria as the clot, I would have thought there would have been secondary platelet aggregation, and maybe there is, but for whatever reason, the outcomes show that hemorrhagic transformation is just much more common with this etiology of stroke than your traditional atherosclerotic stroke. So the answer is antibiotics only. Okay, cheery subject, dementia. Dementia, the definition of which is just a progressive cognitive disorder that interferes with activity of daily living and functioning. That is an important working definition because there's a concept called mild cognitive impairment, which is sort of a potential precursor to dementia, where you have measurable deficits on exam, but no interference with your function in daily life. CNS imaging is appropriate in all patients with dementia. It's not necessarily indicated with MCI or mild cognitive impairment. That's why that definition is particularly important. But about 5% of people will have a lesion on MRI or imaging that could be explanatory for their cause of cognitive impairment, hence the indication for that imaging. Always look for reversible causes. This makes sense. It doesn't often happen in practice, but you wouldn't want to miss a potentially reversible cause. This includes B12, thyroid disease, and then that's the standard. If they have history indicative of potential syphilis or other things, you check for these other things, including alcohol and HIV, but generally it's based on the history, not the standard shotgun approach. Consider pseudodementia or dementia due to depressed mood when they have trouble with attention and concentration, forgetfulness, or effort on examination. They often retain ADLs. They can do well in office testing, but their concern kind of outpaces the actual measurable deficit. Alzheimer's disease, the most common form of primary dementia. You get memory, usually amnestic Alzheimer's is the most common form, plus one of the other ones, visual, spatial, executive, language, or personality dysfunction. The pathology, of course, is amyloid and tau protein accumulation. And then acetylcholinesterase inhibitors are indicated for mild or moderate disease. Once they develop severe dementia, there's probably not much role at that point. All you get really is the side effects. You can also consider 2,000 units of daily vitamin E. Memantine can be used for moderate to severe. It's pretty well tolerated, but it may not do too much. And then mild cognitive impairment is not treated at that point. And there's no FDA-approved treatment for MCI, but there is for Alzheimer's disease. And even though it's not always a precursor, you do have an accumulative risk once you develop MCI for Alzheimer's disease. And again, you can see here the standard evaluation, which I mentioned verbally just now, and the case-by-case basis, which is not routine, but again, based on history. There is a differential diagnosis for Alzheimer's dementia. What's interesting is Alzheimer's is probably the most common cause. The second most common cause of dementia is actually vascular dementia or multi-infarct dementia, which can really present two major ways. What we kind of consider the accumulation of ischemic deficit in the brain causes an accumulation. It was described as a stepwise dementia, but if you're not measuring it that frequently, it probably just looks like any old progressive dementia. It can be hard to tease out how much ischemic burden is the cause versus primary Alzheimer's because they often coexist. MPH we talked about previously, so I may sort of skip that for the sake of time. Lewy body disease can be thought of as on the spectrum with Parkinson's disease, so essentially dementia with a lot of Parkinsonian features. The other additional features are a lot of fluctuation, which we don't often see with dementia. Hallucinations, which are described as visual hallucinations that are considered like little people in the corner of vision, often thought to where the little green men mass conspiracies come from originally. Frontotemporal dementia, not a common cause of primary dementia, but terrifying. As you get younger in onset, can cause robust personality changes or disinhibition, hence the frontal lobe stuff, and can be very debilitating. And then lastly, and very scarily, CJD, probably the most infamous of all the rapidly progressive dementias, which kind of is a topic in and of itself. Features to distinguish that from Alzheimer's, of course, is the progressive nature of it. The startle myoclonus, they'll often have a jerking movement associated with light noises when entering a room. The EEG has a characteristic appearance in the mid stages of the disease. The MRI is classically taught as having what they call cortical ribbon sign, and for testing purposes, that's probably the most common form to see it in. A sort of subcortical to cortical ribbon going all the way around the brain is how it's typically tested, or typically on tests. It turns out the imaging characteristics are very variable. But the protein you're looking for most commonly in the CSF is something called 14-3-3, and that's what would be on a test. Medication approach to Alzheimer's, I already kind of mentioned. These are just more specifics, but they're basically based on class. Acetylcholinesterase inhibitors really don't affect progression, but may retain function longer. There are significant side effects, so not every patient wants to be on these because the GI stuff can certainly be a deal breaker. You want to test for EKG prior to starting, and then memantine can be reasonable add-on therapy for moderate to severe cases. Audience response question number 11 is a 25-year-old female with multiple sclerosis who developed worsening numbness in her legs yesterday. She has had numbness in her legs chronically from prior transverse myelitis. She has no weakness, incoordination, or visual change. no other new symptoms. Her temperature is 100.1 degrees Fahrenheit. White blood cell count's 11.5, and the urinalysis confirms a UTI. Which of the following is most likely to improve this patient? A, antibiotics. B, IV pulse of methylprednisolone for an MS flare. C, gabapentin, or D, pregabalin. The correct answer is antibiotics. This is a bit of a controversial stem. What this is trying to illustrate is that there's such a thing called a pseudo flare, which means that patients with MS have an unfortunately poor neurologic reserve, and even mild illnesses like an UTI or other things can re-exacerbate pre-existing flares. So her history of the leg numbness was a tip-off, and the presence of a UTI was another one. Now, sometimes you can be mistaken and call something a pseudo flare, and you get an MRI and note there's a new lesion, and hence this was actually a new flare, in which case the right answer would be IV pulse of methylprednisolone. And that's, by the way, the correct answer for the time being. There are some studies to show that high-dose PO steroids can be used in lieu of IV infusions, but I imagine testing circumstances would still prefer probably pulse doses of IV steroids as the correct answer. MS, a very terrible disease, has a slight female predominance, usually starts in 20 to 40 years of age. Vitamin D deficiency was a slight increased risk, or at least they noticed that epidemiologically. So checking for vitamin D deficiency is reasonable with supplementation if they're deficient. Diagnosis is the classic dissemination of space and time. So you want to have lesions in different places or different parts of the body, and then over time. Otherwise, it doesn't meet the clinical criteria for MS. Because the MRI technology has gotten so good, there's a lot more imaging characteristics or add-ons to the traditional McDonald criteria, which used to be predominantly clinical criteria, but now adds a lot of bells and whistles for MRI-based criteria. So our diagnosis is a little more accurate these days than they used to be. There's a wide variety of clinical symptoms because, again, it's multiple sclerosis or scarring of multifocal areas of the nervous system. But fatigue, weakness, spasticity, and bladder dysfunction are some of the most common, as well as optic neuritis, as well and diplopia. You can get paresthesias, pain, ataxia, basically a gamut of neurologic symptoms. There is a phenomenon of worsening with increased body temp, what was known as Uthoff's phenomenon. So people going out in warm weather would often experience at least a slight worsening of their prior symptoms. And again, we're looking for subcortical or white matter CNS plaques on MRI. It's a lot of it's supportive diagnosis. Getting an LP looking for an increased IgG index is often now no longer required, but used to be a supplement for the old McDonald criteria. You're looking for increased IgG index and oligoclonal bands in the acute phase of a flare. You can actually do evoked potentials as well, but again, not commonly done anymore. This is a video of a woman who is trying to look alternatively to the right and left. And if you can't appreciate it in the audience, what's happening to her eyes as she's asked to look right and left is the opposite eye can't look all the way laterally. So for example, when looking left, the right eye can't go midline, and looking right, the left eye can't go midline. So basically she can't adduct the eyes in either direction. And this is bilateral INO, intranuclear ophthalmoplegia, almost totally specific for MS. It's really hard to get a lesion that small in any other condition. There are definitely exceptions, but by and large, a high association with an INO and MS. For acute exacerbations, as mentioned, it's IV methylprednisolone, trying to look for pseudo-exacerbations via any infections or provoking causes. There's a whole host of disease-modifying therapies. It's probably doubtful you'll encounter them as a prescriber, but it's probably good to know some of the side effect-based associations with these for testing circumstances, as well as clinical circumstances. Natalizumab is one of the newer medications, although there's always newer ones on the market in which the test will probably lag. The ones to really know is that in natalizumab, you have a risk of something called progressive multifocal and leukoencephalopathy. And as it sounds, is pretty terrible, progressive disease of injury of the white matter, which is exactly what you don't want when you have MS already, often associated with infection, endemic infection of the JC virus. So prior to starting natalizumab, for example, it's standard of care to get evidence of JC virus infection, in which case you would avoid that medication. And the newer medication of fingolimod, one of the newer ones that's a nice oral option, has potentially severe bradycardia, so getting an EKG prior to that one is important. And again, in an effort to respect your time, I'm going to go very quickly. Neuromyelitis optica, a related CNS inflammatory disease that causes it's sort of like a more specific form of MS that attacks the optic nerves, sometimes bilaterally, as well as the spinal cord in a more acute fashion. And the high yield thing to remember here is that the antibody most commonly associated with the disease state is aquaporin 4 or NMO antibody. And so if a test question comes up, it might, and it would be aquaporin 4 is the correct answer. Neuro is a big chunk, a big topic, and I thank you for your patience and willingness to do this virtually with me.